Good afternoon, everybody. It's always nice to get I'm not blaming the organizers, what we call in rehab, the graveyard slot. Everybody's ready to go home. Sorry, I won't keep you any longer. My background, surgical, but then probably over 25 years ago, I moved into rehab. But quite interesting journey. So I've been asked to talk about amputation and the long-term outcomes this evening. I'm going to try and get through what we're going to talk about. Just for disclosures, I kind of dabble into all sorts of things, really. Jack of all trades is kind of some of the stuff we do. And our latest stuff is looking into use of virtual reality in all sorts of things, neuro rehabilitation, amputee rehabilitation, and I'll come to some of this in one of my slides when I'm talking about managing some of the problems that develop after amputation. So these are some of the areas I'm going to cover in terms of this talk. Now, amputation, I'm speaking to the converter. By the way, how many people involved actually doing amputation? So quite a fair number of people. So we're probably going to be able to skip over some of the slides there. So there are quite a lot of things in terms of amputation we can talk about. I always like to start from the history. And historical perspective is quite important because this has been going on for very, very, very long time. It's one of the things humans have been involved since medieval or even before medieval time. Even I remember myself as a house officer, this is the first procedure I ever did in A&E. Almost kind of like a guillotine amputation, and it still sticks with me up till today. And before then, we all just always think people just take the limbs off. But actually, with increasing archaeological evidence, not only were they taking limbs off at that time, they were actually also providing prostheses. So we're learning more that actually what we thought was actually quite crude, those people were a lot more refined than we gave them credit for. And over the years, the surgical techniques and how it's performed has evolved. I think the rapid change happened after the Renaissance with improvement in surgical techniques, people also surviving, and then when antiseptic techniques were also introduced. The era of using carbolic soap by Joseph Lister actually changed a lot of things because before, when they do amputation, let's say on a ship, they basically do a guillotine. Person is lucky to survive, or if they survive the surgery, infection takes care of the rest. And with modern amputation techniques, increasingly, patients want more after the amputation, which is where some of what I do come in from a rehabilitation perspective and giving them a prosthesis or what I call a new lease of life. And as I said earlier, we thought it was more that the development of prosthesis was as a consequence of modern evolution of amputation, but it's actually something that's been going on for quite a long time. And one of the recent events was a discovery of a skeleton in Borneo. And this person has had amputation, which they date back to 31,000 years ago. But not only that, what they describe in their finding is similar to the last X-ray, and the X-ray shown by the last speaker, which is a good amputation storm that has healed very well. We showed people have actually cared for that person after amputation, which basically means they were also doing rehabilitation at that time. In terms of indication, I run a pre-amputation clinic, and one of the things that comes is when people come, we look at what are the indications, what are the surgeons thinking of in terms of wanting to amputate. We call it the 5 Ds in terms of the indication. Almost everything will fall into one of these. If you're dealing with diabetic foot infection, it's either dead, it's either dying, or it's decaying. And if it's a wet gangrene, it is dangerous. Or if it's a bone tumor, it is also dangerous. It's going to take that patient's life. And there's a group called the Damn News as Apology. I don't want to swear, but these are patients who've developed what historically used to be called complex regional pain syndrome, sympathetic acrodystrophy, and stuff like that. And you have some of these patients who come to the pre-amp clinic who's got a painful an aesthetic limb that looks fantastic, normal, and everything, but they can't function. We've got variable success in terms of that. Certainly, you can do the amputation. It's what happens after. The amputation is always a problem. And you have to dig into that, and I'll talk about that when I'm talking about the pre-amp consultation. You guys know more about this than I do in terms of all the different measures you can use in terms of guiding the decision whether you're going to amputate or not. But generally speaking, over the years, it's interesting. When I started rehab in early 2000s, the number of amputations we perform in the United Kingdom has almost remained stable, roughly 5,000 per year. It's just why, nobody knows, but it's roughly at the same lower limb amputation. We don't do a lot of upper limb amputation because you want to try and conserve as much as possible. But majority of the lower limb amputation, everything has more or less remained the same level, 5,000 every year. But what's changed is where it's been done. Unfortunately, in the northeast of England, we seem to be leading in terms of that. And it's not really a bad thing, because I've said this to many of my vascular surgeon colleagues. They're always kind of like, we need to reduce our amputation rate. I said, no. I think we're actually getting more people in terms of quality of life. And fine, I'm a rehab, people getting back into their life. And what are the goals we look at when people, or I'm saying, I think at this point you should be considering amputation. You want to remove the disease focus. Now, we don't look at amputation as a last resort. So if somebody's got osteosarcoma, for instance, that's your primary treatment. It's not a last resort. You're saving that person's life. And you're controlling disease progression. And it also allows for sometimes for you to be able to do some of your reconstruction. But for me, the most important bit is that stump, or we call it residuum or residual limb, that becomes something else. Because that's the most important bit of the whole amputation stuff. Because it not only the remnant of a limb, but it now becomes a new physiological organ, which is where proprioception and everything, and if you get it right, it makes the amputee internalize using that prosthesis. It becomes almost like a second appendage, and the body adapts to it easier and better. So that's important in terms of how and who does that and getting that very right. And that's one of the aims of what we want to achieve. It also allows us to be able to use some of the more advanced prostheses that's coming up increasingly. So if you give examples, so we've got those you've seen patients with blades and different multi-axial limbs, and you can have all the different fantastic mechanical components or technological components in your prosthesis. If the residuum and the socket mismatch, they're not going to take advantage of any of those other things. So if you have somebody who's a transfemoral, we can give them what we call a microprocessor knee. And the microprocessor knee used to cost about 50,000, but it's come down now. We can get it for like 15. But if the socket and the stump don't match well, they're not going to get to that face. So what are well, you all know the basic principle. There's this argument in terms of myoplasty and myodesis. For below knee, everybody's going to end up with a myodesis. Anyway, that's not really the issue there. For above knee, myoplasty is important, especially when you're looking at your adductors. And this is one of the problems for us when we get some of the patients, especially those with a short stump. All the hip abductors are still intact, so you've got a stump that's sticking out this way. And then you put a socket in, that starts rubbing on the side. Patient is absolutely furious. You told me my life was going to be better after the amputation, now it's worse. So that's important. So for people who then do transfemoral, if they can do a myoplasty with their doctor to try and bring it back, that helps. Now, some people compensate by making the limb long, not particularly because they said, then we retain the insertion of the adductors for as long as possible. It's a balance, because you also have to think in terms of if the stump is too long, then there's no space for prosthetic knee joint. So if the patient sits, one knee is here, the other knee is down there. So because females absolutely don't like that. So all these are considerations that has to be borne in mind when thinking in terms of that. This is now more or less the rage of the moment, targeted muscle renovation. The whole idea is to manage pain and prevent what we call phantom pain sensation. In fact, just last week, NICE released the guidance on this. The plastic surgeons and vascular surgeons are really so. The few I've seen done in many of the patients hasn't really achieved this, but everybody's pushing on. Maybe the more they do, we will see. The whole point is trying to get the nerves to bury it back into the muscle to get it to reinnervate, and the idea is that will prevent the formation of neuromas. Now, I've always argued, what's neuroma? You cut a nerve, you're going to end up with a neuroma. It's whether the neuroma is painful or not. You always see a neuroma the same way if you cut the skin, you are going to have a scar tissue. So it's either it become impacting or not. So the idea that just seeing a neuroma means it has to be treated. No. Is that the cause of the patient's pain? And there are different ways you can tease that out. That's the cause of the problem, and that's not the cause of a problem. You can do MRI scan on every amputee you've seen. You will see in most of them different levels of neuroma formation, but they're fine. If it doesn't cause any problem, why bother to treat it? So that was just last week. Some of my colleagues contributed into that NICE guideline development, but this has just come up. We'll watch the space and see how that comes. This is just a slide to show the different levels in terms of amputation. What I always say when I get the patient in the pre-amputation consultation clinic and I do my letter back to my colleagues, to Professor Sharma, and I always kind of say, okay, we should go for a transtibial, yeah? Or we should go at this level. Mid is usually quite good. You don't want the momentum too short, neither do you want it too long. Either doesn't really help. When it's too short, it's difficult for us to get the suspension right. When it's too long, it becomes very difficult to put in other components. But there are minimum levels. What I probably shouldn't be saying this out loud. The length I say, this is the minimum. We can actually do shorter, but you give them a little bit longer, just in case. And sometimes also, when you're dealing with somebody, especially the diabetic patient with peripheral vascular disease and stuff like that, they're not sure whether they're going to get good healing residuum. So they allow a little bit more tissue. Then fortunately, the patient heals. But then now they've ended up with a long residuum. Now for us, in terms of prosthetic fixation, we only do what we call the major limb amputation. Major limb amputation is anything from the ankle and above. Anything below that or further distally is considered minor. So a ray amputation in the toe, transmetatarsal, choppers, and co. No, I don't give you prosthesis for that. I can give you a toe filler. It's more of an orthosis. And the problem with them often is what you then get is the rocker problem. When you're having toe off, when you're walking, the silicone you put on the shoe will start rubbing on the front of the stump. So what you correct that is you just give a sole, you change the sole of the shoe and put it like a rocker. So when they stand, they just roll over. And you can do it in such a way, they're very clever now. You wouldn't even know people wearing normal shoe because the old orthopedic shoes, most patients nowadays will not even want to be seen in them. So you have to make things to make it trendy and acceptable. Because you'll be shocked. Every time they leave the clinic, we give them a new limb. You can best, it's going to go on Instagram or it's going to go on social media. They have to show it off. So you have to make it look nice. This is the model we use in rehabilitation. You've all heard of the ICD, International Classification of Diseases. We tend to use what we call the International Classification of Functioning. And what you then do with that is look at whatever the condition the patient has got, you look at it more from whatever health condition, you look at it from 3 domains. In terms of the body function affected, the activity limitation the person is unable to do, and what in terms of participation. So I'll give an example. You got somebody who's ended up with an amputation, which is a body function. What activity will they be unable to do? They can't walk around. That's the simplest thing. But what participation? Then he can't go to work, he can't run around, he can't play with his kids or his grandkids. And when you look at an individual is more than just, let's say, oh, this person is a doctor. It's more than that. It's either a father somewhere, an uncle to somebody. So loads of other roles that people want to fulfill. But whatever you do for any patient is influenced by two what we call contextual factors. That's the environment and the person itself. So you can make people disabled by altering the environment. There's a fantastic video I use for medical students on YouTube, which looks at by EDF, and it shows able-bodied people struggling in a disabled environment. So somebody walked into a library and all the books were in Braille. So you can't read. So it's not necessarily, you can use the environment to disable people, even though they've got no impairment. So those are some of the things we cover in our pre-amp consultation, and we address the concerns. And you have to set the goals. What are you aiming to achieve in terms of what do you think the amputation? And what I always tell people when we come for pre-amputation consultation is, I'm not going to tell you this is the best or this is, I'm going to give you all the different options. Our typical pre-amp consultation takes minimum of an hour, and that's a multi-day, and a good conversation. So I usually stick them up towards the end of the clinic because you think you've covered everything, they have more questions, and rightly so. You can't go back to be putting it back once you've taken it off. And sometimes I offer them a second or even a third. And you'll be shocked, actually, we run the limb center, which is not far from here, artificial limb center. Up till probably 6-7 years ago, we actually didn't even have a psychologist for our service. We proposed to remove somebody's limb, but we had no psychologist support. And then I had to threaten before we got psychologist support for those patients. But those are some of the things we have to do in pre-amp consultation. Then they've had the amputation. What do? We go through different stages. There is the early postoperative, and then there is the point where we get to the point of giving them a prosthesis and they can take it home. We initially work with them, and the physio will do that in clinic. They don't get to take it home until we're comfortable that they will be able to use it. And there are different levels and different things, parameters we kind of go through. Now, in terms of what are the outcomes? Outcomes from amputation is no one size fits all. Everything depends on the different circumstances of the different patients. So things like the amputation level, how much support is available to the patient, and then also prosthetic. But the prosthetic component, I think sometimes we overblow it. I don't know if anybody has ever heard of what they call the Jaipur knee. The Jaipur knee is an old, clunky knee component. I think it costs less than $5 to make. It was developed in India. Uniques are fantastic. But you wouldn't give it in many of the developing countries. But you see patients with Jaipur knee climbing palm trees. So we all know it's not the prosthesis, it's the person. But if I give people here, they're going to, I want the microprocessor knee, I want this type of knee, I want that type of knee. Or they come and say, I watch a YouTube video of somebody playing golf. So I go, do you play golf before your amputation? No. So why do you think suddenly if I give you a prosthetic limb, it will make you be able to play golf? But those are the kind of things you have to deal with. Another long-term outcome is in terms of returning to work. We run a same-day service. We used to give 2 limbs to patients before. We stopped that in the NHS. You get only 1 limb. And the reason for that is when you give them 2 limbs, it's like a pair of shoes you've never worn for a long time. The day you decide to wear it doesn't fit. So we were wasting huge amount of money. We did a lot of review, and across the country, we all decided you're only going to get a limb, but if you need a repair, we can do the repair same day. You come into the center, you're drinking your coffee, they've sorted it out, and you can go back to wherever and whatever you do. We don't have figures in terms of how many people end up becoming able to go back to work. Again, it's complex. I always said going back to work has nothing to do with disability. It's either you want to go back to work or not. And I always be very upfront with many patients. Do you want to go back to work or not? So don't let's beat around the bush. It's not a disability thing. If you want to go back, most places can make reasonable adjustment to accommodate that patient. What are the longer term issues? Pain is one of them. And you have phantom limb pain as different from phantom limb sensation. You can have ongoing problems in terms of skin, which we have to manage. And in some cases, I've had to enlist the help of dermatologists to help in managing them. They do develop musculoskeletal problems, and as I said earlier on, socket fit is the most important. Socket fits everything. The psychological component is also very important. Many people grieve for the loss of the limb the same way you grieve for a loved one. And that's important. If people have no adjustment to that limb loss, no matter whatever you do, no matter whatever you do, they have a poor outcome, especially when they develop maladaptive coping mechanisms. And in terms of rest pain is different from in terms of, there are two types. You have the phantom pain, phantom sensation, and I've talked about the neuroma. There are different things we do for different ones in terms of, but one of the things that do work a lot, distraction. You've heard of the mirror box therapy, Ramachandran, where you try and trick the patient to try and get them to relax the amputated side using the mirror box. So you have a mirror to face the normal side, and when they look into the mirror, an image of the normal side is projected on the amputation side, and they can relax that amputated limb that's no longer there, that's causing them problems. We've tried to replicate that into some of our VR apps, and we did that with Sheffield. They've done a very good program, but for whatever reason, they don't want to release it into the public, but you can do that, put a VR headset on, and the patient also imagine and get that relaxed there. Some of them, the number one reason for most amputations we deal with in the UK is peripheral vascular disease with diabetes. So many of them still have ongoing these vascular problems. And some of the pain you're seeing is because that is progress, not because any particular problem. Now, one of the interesting things that's always come up with, some do well, some don't do well. Who are the best people that should really be doing the amputation? Is it orthopedic surgeons, vascular surgeons, plastic surgeons? And this particular study was quite interesting. I suspect it was done by orthopedic surgeons because they were really kind of like, oh, outcome and everything is all right. But what they realized is there were less complications by the one done by the orthopedic surgeon, more with the general surgeons and vascular surgeons. But that's not rocket science. I actually think that's right. Why? Most of the patients you are dealing with are trauma or similar type of patient. They do well, very well. Even as an amputee, when we get them for limb fixation, most are young, most are fit, you can get them. You don't get crushed if you're somebody sitting in your house. It's somebody who's out and about that gets hit by a car. So those are people, it's the same when you have military patients. They do very well. They're young, they're fit, they're at the peak of fitness. Whereas most of the people vascular surgeons are dealing with at the peripheral vascular disease, they're deconditioned, most haven't worked for a very long time. And they delay because they're doing all sorts of aortofemoral bypass, so all sorts of revascularization. Now, the problem for me is often this. The period you're trying to wait to conserve that limb, it could take up to 2 or 3 years. That's 2 or 3 years, that person is never, ever going to get back. It might be a crucial period in terms of family life, interacting with their family, being able to get people out, and they can't do any of that. So those things are important in terms of consideration. Yes, it's nice to try and conserve a limb. Amputation is not a failure. And I've always said this to many of my colleagues, it's not. It's looking at it in a way to manage what is in front of you. Is it that person's quality of life? One of the videos of one of the presentations where on the foot, and the guy didn't want an amputation, and he was walking with 2 elbow crutches, and fantastic. Now, the energy cost of that walking compared to my average transtibial patient. By the way, if you have any transtibial patient, if they walk into this room, you will not know. A transfemoral, yes, you will notice and get different, but a transtibial, absolutely no. In fact, the current joke is earlier this year, one of my transtibial patients went for MRI scan, and they put him in the MRI scan machine with his prosthesis on because they didn't know. He was wearing trousers, and they put him in an MRI a few months ago in the same city. So that's how much these people and the prosthesis. But we used to put a lot of cosmetic cover, but nowadays they don't like cosmetic cover. People like to show the metal. It's almost kind of like a badge there. Now, in summary, and to round up, you can get patients with fantastic quality of life after amputation, even for those that do not successfully get a prosthesis. Because what I say to them is, look, you can talk, you can get out, you can do anything you want to do. And the environment here is so conducive. You got sidewalk, you can put a patient on a mobility scooter. I was in the Far East in Japan a few years ago for a conference, and they actually have wheelchair that you can pretty much program with the postcode, put a patient on it, and you'll take the patient to where you want the patient to go, almost like a driverless Uber kind of thing. So things are there. One has to look at all the different options. But if you get to that stage where you want to, wherever center you work in, and go speak with your rehab colleagues or that, and come to, but it's almost, I always sell it to patients in terms of it's a new lease of life to be able to do things they couldn't do before. Thank you.
Great slide. Thank you, Dr. Salam. Any comments or questions for him?
Yes, thank you, Dr. Salau. I'm from Nigeria. Yes, exactly what you said concerning above-knee prosthesis and below-knee, that it is better with above-knee. Some of the undocumented practices I have done in diabetic and peripheral vascular disease patients in Nigeria, even those that require above-knee amputation, we tend to take double consents. We tend to do a below knee and see if it will survive. If it doesn't, then we go above knee. And up to 80 to 85% of my patients actually pull through with a below knee. And the prostheses are better. It is cheaper, it is much more manageable, and the patient is happy because the patient does not want anybody to know he's having an amputation. So I think the below knee prostheses are much, much better for patients to manage.
Yep, it is. In terms of energy cost and consumption, for every step you take with a below knee amputee, you're using 20%, roughly 20% extra energy for every step. For a transfemoral, that increases to almost 50% extra. So that's one in terms of that. You can increase the chances of your transtibial stump surviving if the what they do here is a lot of all the vascular surgeons, when they do all their revascularization procedure, they do a lot of femoral popliteal bypass and co. That helps to give you a good and durable residuum. The problem is when you have to go distally, and this is one of my conversations with the vascular surgeon. Diabetes is medium and small vessel disease. Often not amenable to any of your tying this vessel to that vessel there. So the moment you start having toe and co going, you're going to end up, I call it amputation in stages. They take one toe off, they get to transmetatarsal, then you go to below knee, almost in stages, but you know you're going to end up with a below knee. But if you get the revascularization, you can get that knee. The knee joint makes a massive, massive difference in terms of function, in terms of energy cost, and in terms of a lot of things. So yeah, you're doing it in the right way. The only thing is just that you can increase the chances of that. And if your patients are active after, they actually also improve the likelihood of that surviving. Yeah. It's quite interesting to hear that they get prosthesis also, because I remember, and I'm going back over 20, almost 30 years ago, when I was still practicing in Nigeria, when we end up with amputation, we do the amputation for the patient. Some of them don't actually want prosthesis because then they can go, for those who are vagrant, they want to use it to beg. If they have a prosthesis, nobody's going to give them money. So that was the then, but it seems things have changed now.
I've got a question from Ross here.
Yomi, thank you very much. That was wonderful. Just about targeted muscle renovation, you mentioned there's a nice guideline that's come out. I haven't actually come across it yet, but I did have a patient earlier in the year who was asking me about it and struggled to find anyone who was offering it, certainly within the Yorkshire region. So how widespread is the availability of that now?
Of what, sorry?
Of targeted muscle renovation, TMR.
TMR is not widely done. What's the name? Ms. Chu, actively interested, and I tried with George Smith and co. We were trying to see whether we can, that was before these nice guidelines came out. We were trying to see whether, she's certainly, I think she'll be quite keen to explore it. She was really, really very keen in terms of doing that. There are some in Leeds and Manchester who are doing it. Manchester, certainly, they're doing some. And I think some people said in East Anglia. But it must be quite a few people are doing it. That for NICE to get involved to put a guideline quickly out. I can get you the Manchester folks. I know those. Yeah.